Chamber's Governmental Affairs Committee, I want to thank you for joining us for our forum, Onslow. The Governmental Affairs Committee works with government agencies on issues that affect our business community. We monitor legislative issues that impact local businesses, and we promote partnerships between business and government, military, and education. And we use these forums to create awareness on topics that are important to our entire community. I would like to thank our media sponsor, the Daily News, City of Jacksonville, for the facilities and assistance. And our corporate sponsor today is First Citizens Bank. At this time, I'd like to call up Buddha Howard, Senior Vice President for First Citizens Bank.
Thank you, Ralph. And on behalf of First Citizens Bank, we appreciate the opportunity to be a part in bringing this forum to the citizens of Onslow County. At First Citizens Bank, we have a saying that kind of goes, money isn't everything, but so much depends on what you do with your money. Now, one would argue that your health is everything. And to that point, we were especially excited about being able to be a part of bringing today's forum to the citizens of Onslow County. We want to thank the Jacksonville-Onslow Chamber of Commerce and the Governmental Affairs Committee for their part, as well as the other organizations and individuals that had a part in this. So with that said, we hope that you find today's forum informative as well as useful, and we're looking forward to it. So thank you.
Welcome to Forum Onslow. Big thank you to the Chamber of Commerce, Lorette and Janet, not only for the suggestion to present this incredibly relevant topic, but also for the hard work involved in bringing this event to fruition. I also would like to thank Buddha Howard and First Citizens for sponsoring this event. We appreciate you always. You're such great supporters of furthering the healthcare cause in our community. I am grateful for the opportunity to introduce you to representatives from the North Carolina Hospital Association to discuss the economic impact of hospitals and health systems in North Carolina. The topic is particularly relevant because of the changing and uncertain nature of the healthcare industry at this time. In order to provide some clarity, we have with us today Emily Rowland, who is the Member Advocacy Coordinator with NCHA, and our speaker, Stephanie Magera. Stephanie is the Vice President for Public Policy for the NCHA, where she currently analyzes and develops public policy recommendations for North Carolina's hospitals and health systems. She also works with NCHA's Policy Development Committee to identify, develop, and implement a strategy for healthcare transformation in North Carolina. Stephanie?
Thank you, Penny, and Forum Onslow for having me here today to talk about our economic impact of hospitals and health systems in the state of North Carolina. So earlier this year, we worked with the Research Triangle International Company, or RTI, to help us assess what the economic impact of hospitals and health systems are in our state. Frequently, we talk about hospitals and we think about them in terms of providing health care, and that is certainly true, and our patients are front and center, but we also provide a lot in terms of the state's economy, jobs, investment as well. So we wanted to try to measure that. And today I'll talk briefly about the healthcare industry in North Carolina, kind of give you an overview of that, then what the economic impact of North Carolina's hospitals and health systems are to the state, and then lastly, some of the significant workforce challenges that we are facing. So first, a little bit about the healthcare industry. To put this all into context, North Carolina and our population is projected to continue our rapid growth, and you can see we are growing rapidly. The line points straight up, and we officially became the 9th most populous state as of 2014. We surpassed 10 million people in 2015, and we're projected, this comes from the Office of State Budget Management, to hit 12 million people in 2035. I don't know in terms of will that move us up from 9th to 8th or even to 7th, but even several years ago, North Carolina wasn't in the top 10. And so we can see as some other states that are larger than we are maybe lose some of their population, we're definitely one of those states on the whole that continues to gain. Interestingly, by 2035, more than 1 in 5 residents will be 65 years or older. So in healthcare terms, that says a lot about our Medicare population and the population that we treat and maybe some of the health conditions that we'll see. It's slightly less than the nation as a whole, which will have around 21% of our population in the U.S. will be 65 or older, but certainly still a significant change, especially when you consider that only 13% of our population was more than 65 years or older in 2010. So this is probably not a surprise in Onslow or anywhere else in North Carolina that our industry mix has really shifted over the past 20, 30 years. From 1990 until today, we've seen a 46% decline in terms of manufacturing jobs, and we have seen service jobs increase during that time. You can see healthcare actually surpass, that's actually healthcare and social assistance, surpassed manufacturing back in around 2005 in terms of the number of jobs. And other services industries are growing as well. Hotels and restaurants, administrative services, which includes some of the back office support, janitorial services, things like that. Professional services, which are architects, lawyers, IT folks, and then finance and insurance. What that means in terms of wages is that the wages for different industries and services, for example, frequently are not as high as you see in manufacturing. Hospitals and healthcare and social assistants are actually one of the higher paid services jobs behind professional services, which again are those architects, the lawyers, those folks. And certainly are much higher than hotels and restaurants, wages in retail trade, and in administrative services, but are not quite as high as manufacturing. And you can see this over a period of time of 1993, 2003, and 2013. So North Carolina's healthcare industry as a whole, as Penny alluded to earlier, is definitely in transition. The Patient Protection and Affordable Care Act, or Obamacare as some people call it, was signed into law in March 2010. We are definitely in a underway in this transformation to population health, where we look at the health of the whole population, and hospitals and other healthcare providers are incented to treat the health of the whole population rather than just on a per case basis. Also, many of our hospitals in the state have joined health systems, and we've seen more of our physicians who are now employed by or aligned with health systems. And then we've seen a move from volume to value-based care, hastened by the Center for Medicare and Medicaid Services policies. I would say that in some ways, what CMS does is moving us even more quickly in terms of how they decide how Medicare and Medicaid gets reimbursed to hospitals, health systems, and other healthcare providers. And as someone who traditionally did not come from the healthcare industry, I actually worked in economic development for a long time. This is something that's been a little bit surprising to me, and maybe to you as well, that CMS and how they do their payment gets copied in a lot of ways in the private sector too by the private payers. So they sort of are leading the way, and is another reason that we're experiencing this transition. Again, as Penny alluded to earlier, the repeal and replace of Obamacare we're really not sure still what's going to happen with that. I think in the last 2 weeks, the recent measure, the Graham-Cassidy Amendment, failed. And so again, we're in this state of uncertainty where we're not sure what's going to happen with our marketplaces, with Medicaid in some states. North Carolina was one of the 19 states in the country that did not expand Medicaid. And so while we're in this transition, we're still trying to figure out what's going to happen as Congress continues to try to discern what they're going to do with the Affordable Care Act. So that sets the stage in some of the policy context. The other thing that is important to consider is where we are in terms of our overall health. And so North Carolina is actually ranked 32nd in healthcare, over our overall health and our public health scores in the U.S. You can see the Southeast and even the Deep South tends to lag some of the northeastern states and western states as well in terms of our public health, in terms of how we do. It looks at various health conditions, heart disease, alcoholism, other health measures. And in North Carolina more specifically, we do serve all people, but we definitely have a lot of vulnerable populations. So you can see this is the state as a whole, and orange represents census tracts with 20% more of the population that lives below poverty level, so people who are less likely to be able to afford or go seek health care. And the purple represents tracts with 25% or more of the population with less than a high school diploma. Magenta is where those populations are above both of those thresholds. Onslow as a whole actually fares much better than some of its neighbors, but we do have some of those tracts with more than 20% of the population below the poverty level. And you can see in the pop-out part for the county, that's where some of those tracts exist. So why do we talk about wages in terms of health care? Again, coming from the non-healthcare side of things, I would say that social determinants of health and that idea was not something I was familiar with until I started working in healthcare. And what social determinants tells us this is a model developed by the University of Wisconsin, is that our health outcomes and our behaviors are actually determined more or by social and economic factors as they are by our access to care. So you see on this chart that clinical care, the quality of care that is provided and the availability of it only makes up about 20% of our outcomes. Our behaviors, tobacco use, diet, and exercise, makes up about 30% of what's going to happen to us. But a big portion of what determines our health factors are our social and economic factors. Do we have a good education? Do we have jobs that pay high wages? Are we employed? Do we have family and social supports in place? And do we live in safe communities? And then another 10% is our physical environment, our air and water quality, and do we have access to adequate housing and transportation? Can we get to where we need to go? And I think this is, in a way, as we look at the population health model and the transition that healthcare is making to that, you can see that there are a number of factors that play into someone's health outcomes that you can see more of a partnership being made statewide and locally between our hospitals and health systems, our economic developers, our chambers of commerce, and others in the community to look at this in a much more fuller, broader picture of health. So now, given that context, I want to talk a little bit more about what we found out about our economic impact. So NCHA, the Hospital Association, members actually provide us through a project called ANDI, or our Advocacy Needs Data Initiative, a lot of hospital-specific data about their operations. So we used operating expenses, and we carved out payroll and looked at those separately, and we used the year 2015. And then we looked at capital expenditures. For those expenditures, we looked at a 3-year average just because that data tends to be very lumpy. So if you build a hospital, a new patient tower in 1 year, it might be really high in 1 year and very low in another year. So we took an average over 2013 through 2015. We imputed missing data as needed, and then we also provided contextual data on employment, revenues, community benefits, hospital sizes, and location. We gave this information to RTI, and they ran it through an M-plan model, which is a traditional tool used to do economic impact analysis. And what we came up with is that these are our payroll expenditures by district, and we did break these into NCHA districts. So the way we carve up the state is into 6 areas. We did that so that no one hospital's information, private information, can be determined from the chart. So you can see in eastern North Carolina that hospitals and health systems spend $1.4 billion each year on payroll in the eastern district, which is that light brown color. And we spend $1.3 billion on operations in the eastern district. So that it excludes payroll and benefits, but covers all of our other operating expenditures. And this is done on a county level, and that North Carolina's hospitals and health systems invest an average of $1.7 billion per year from 2013 to 2015. And the reason we broke this down on a county level so that you can see, and even in the handout you can see certain examples of this in Cherokee when they built a new hospital. And we pulled out UNC Rex as another example in their heart and vascular facility is typically because hospitals tend to announce these investments. So as someone who came from economic development, I would say to you that this is pretty significant in that 1.7 billion per year is a big number. The most recent big economic development project that I could think of that had a large investment was the Apple data center out in the Hickory area, which was 1 billion over 8 years. So we are talking about 1 3/4 of those data centers every year invested in North Carolina. I'm not sure totally what happened here to the numbers, but we'll try to work with that. And you can also see it on the handout. The interesting part to me was also that when you look at the expenditures on a per capita basis, and these are total expenditures, that our hospitals and health systems actually play a larger economic role in our rural districts than they do in the urban areas. So the $831 in the Triangle area or $466 per person in the Charlotte area are much, much smaller than what you see here in Eastern North Carolina, which is $1,700 per person, or either in the western and the southeastern part of the states as well. And the Triad is about $1,000 per person. And not to get too nerdy on you, but one of the things that economic developers and others look at is how, what your multipliers look like and how much in your direct, indirect, and induced effects that it contributes to the overall economy. So the direct impact of hospitals means just what the hospitals employed, 162,000, and these are people. How much we spend in labor income, 11.2 billion per year, and then how much we contribute just on the hospitals to gross state product, which is the measure of the state's size of the economy, and that's 19.2 billion. And then the indirect effects are those effects that take place because of the spending that we do with suppliers, and the induced effects are actually the money that our employees spend in the economy. So all that captured together is what gives you the total effect. So in total, North Carolina's hospitals and health systems contribute almost 400,000 jobs to the state, $22 billion of labor income, and are responsible for about $40 billion in gross state product. Directly, and when you look at the direct impact, that's about 4% of the GDP and about 4% of the employment, but about 6% of the state's total wages. So we're actually paying higher wages in percentage-wise than what we're employing. I think one of the things that people may not always think about is the diversity of occupations in a hospital and health system. And so one of the things the RTI did, and this is for the U.S. as a whole, is look at the total jobs and average wages for the hospital sector by occupation. So you can see that the average annual wage for the U.S. is $49,000. And that is roughly, I'm not sure if I have a pointer here. It's not working. Roughly at the bottom two lines. So you can see that most of the occupations pay higher than the average U.S. wage. North Carolina's wage is a little bit lower than that. And North Carolina's average wage is a little bit lower. And then many of the occupations are significant in terms of numbers, with the highest number, almost 3 million employees in areas such as nurses, therapists, technologists, technicians, and pharmacists. And again, economists tend to get excited about multipliers. So we talked about kind of what those were in terms of the raw numbers. In terms of multipliers, for every one hospital job, there are 2.44 total jobs in the economy. I was pretty surprised by this, having looked at multipliers for other industries. They're usually around 1.2. So this is twice as high as what we typically see for a lot of industries in North Carolina. In terms of contribution to gross domestic product, it's around 2, and labor income is around 2 as well. Hospitals and health systems actually measure what's called our community benefits, and it is what we give back and essential services that we provide. And even though this is captured in the operating expenditures, RTI wanted to carve this out just to talk about it separately because it is a unique component of our industry and not something that a lot of other industries have. So in terms of unreimbursed costs that our members have each year that are measured as community benefits. Those are about $3.6 billion in 2015. It accounts for Medicaid losses and Medicare losses, bad debt costs, and then charity care that is provided without, that we are not reimbursed for. So in addition to those community benefits, we have other significant impacts in our communities. Many of our hospitals engage in local grant making. They lead and partner in community initiatives. Some have pretty extensive worker training programs. Others invest in new technologies and companies. UNC Rex is an example of a hospital that has a capital venture fund, and they invest in companies. And then many have partnered in community redevelopment for as big as downtown, kind of a business park that Wake Forest Baptist contributed to in Winston-Salem, to just local initiatives where maybe a hospital has invested in a local park or facility. Oops, sorry, I skipped one. And then we also have some pretty significant research. RTI just looked at the National Institutes of Health funding. Duke ranked 7th in the country in 2016, and got $338 million in NIH funding, and UNC Chapel Hill received about $270 million. Those investments in R&D, which are outside and not fully captured in the economic impact study, are, at least at these two, largely because of their schools of medicine, but certainly there are other hospitals and health systems as well that receive some related research funding. And so we want to be able to talk about that separate from the economic impact study. So our mission, despite all of what we do with jobs and investment in the community, is really to, remains consistent, and it's to care for all, regardless of their ability to pay. So 1 in 6 North Carolina patients has Medicaid, which is reimbursed at only about 65% of the cost of care. 2 in 5 patients have Medicare, which is also reimbursed at below the cost of care. And remember, we talked about earlier that we expect to see our Medicare population grow nationally and in North Carolina. And 1 in 10 North Carolina patients does not have insurance. So regardless of that, we treat everybody. Our hospitals are open 24 hours a day, 7 days a week, 365 days a year. And it says 265, trust me, we don't take 100 days off. And we also are ready, as you've seen recently in hurricanes and other parts of the country as well, to respond to disaster readiness and response, and certainly in North Carolina with Hurricane Matthew last year. And most of our, over half of our hospitals have operating margins below 5%. So now I want to switch gears and talk a little bit, even though we've talked about the jobs and the types of jobs, some of the challenges that we're experiencing as an industry with our workforce, and why it's important as we go around and talk about this with everybody in the state that we try to start to better address some of these healthcare workforce challenges. So we have several key issues that face our workforce. One is the recruitment of workforce in multiple occupations has been very challenging for us. Another is that we have a maldistribution of workers in several occupations. Another is that we're facing high turnover, and burnout has become a problem in retaining our workforce. And then lastly, as we move to this population health model of care, it's going to change our current jobs, and it's going to create new occupations such as care managers. And we're not completely sure that we are going to have the workforce to make that happen and what it's going to mean in our workforce. So nationally, if you look in just the U.S. healthcare and social assistance, you can see the green line, the upper line is our openings, and our blue line is our hires. So we have a big, big gap, and it's gotten much bigger since around November 2013 through now. And we are still struggling nationwide to fill some of these jobs. Our industry employment, hospitals have added almost 340,000 new jobs since July of 2014. And North Carolina, the Labor and Economic Analysis Division at the Department of Commerce actually looks at star jobs by education. So these are the jobs with the greatest projected employment potential. And they look at it by type of degree. So the font's a little bit hard to read, but you can see high school, post-secondary training, associate degree, bachelor's degree, and then advanced degree. And so we went in and looked at those jobs that are just exclusive to healthcare and put the red stars. So you can see, particularly in advanced degrees, all of them but 3 are exclusive to healthcare. There are other occupations in here that we would hire within our hospitals, but they're not exclusive to healthcare. So there are restaurant workers and others that we may employ in our cafeterias and in our food service. But, so there would be more than the number of stars that you see, but particularly in the associate degrees and even in post-secondary, many of those jobs are in healthcare, and the projected employment potential is projected to continue growing. Around the issue of physicians, this comes from the Shep Center data, and it looks at physicians per 10,000 people. Our physicians are concentrated in our urban areas. As you can see here on the map, the darker the color, the higher the concentration. And there are 2 rural counties in eastern North Carolina that have no physicians at all. With registered nurses, our urban counties do have higher rates of having RNs, and then there are some disparities in terms of the lighter the color, the lower the number of nurses per 10,000 people. Nurse practitioners tend to be more prevalent in the urban areas and for some reason in western North Carolina, whereas eastern North Carolina and in the Piedmont still have many counties where we do not have as many nurse practitioners as needed. And I'm sorry that the news, I have to warn everybody at this point in the presentation, the news does not get any better. Across the United States, hospitals are facing unprecedented turnover across all occupations. This is a survey that was done of about 800 hospitals nationwide in May by Leaders for Today. And their findings are that hospitals will have to replace 50% of their total workforce every 5 years, and that key occupations are facing even higher rates of turnover. So you can see the first row of circles is within the first 2 years, and the bottom row is within the 5 years. And the percentages of turnover range from 47% for non-clinical administrators at the peak, but even 23% of staff nurses. And within 5 years, 63% of staff nurses to up to 70% of non-clinical administrators. So nationwide, part of this turnover is burnout, part of it is retirement, and this looks at the retirement plans, that half of the hospital workforce plans to retire in the next 10 years. In a typical industry, you'd only see about a quarter of your workforce retire within a 10-year window, but we're looking at a much double that rate. And 22% of our hospital's workers plan to retire in the next 5 years. So we are very much on the verge of losing a large portion of our knowledge and experience. And in the graph, the chart there, this was, again, those same 800 facilities. They interviewed and surveyed folks about how much longer they're planning to work full-time. And the C-suite folks are on the left-hand side all the way down to staff nurses. And certainly we're facing big bands of retirement in all of those occupations. This data looks directly at North Carolina and comes from our Andy data system where we talk to our hospitals. These are our vacancies, and the far left, the blue bar is 2005, the orange bar is 2010, and the gray bar is 2015. So you can see by occupation, we had a little dip down in some areas except for occupational therapy in 2010, but most of those vacancy rates have gone back up. I think many of our HR professionals in our hospitals and health systems used to say, we said it used to be 8% was our kind of threshold. They said they would be thrilled if they could get to 8%, because at this point you can see advanced practice RNs are well into the 16% vacancy rates, or 14% for 2015, and they have been there for quite some time, well above that 8% in a lot of our nursing categories as well as in our therapy categories. Turnover still remains high as well, and this is another threshold where we use 8%. And again, even physicians are at 10%, and those turnover rates have slowed down for 2015. But they're well above 8% for, those are nurses, licensed practice nurses, clinical nurses, And again, on the far right-hand side, those are therapists. So as healthcare transition continues, hospital and health system jobs will change. Our new occupations will be focused more on care management and improving the patient experience. We're already seeing that and doing a little bit of work together to say, what should a care manager really do? How should this really work? What skills do you need? How can we work together to sort of figure that out? More care will likely take place in the outpatient setting. So what does that mean in terms of hours and occupations, and how do their jobs shift? And as the workforce changes, the occupations may also change. So some of the other things we're talking about are, what do millennials want in a workforce? What does work look like for them? How do you accomplish home work-life balance? Are the 12-hour shifts for nurses the right way to do this? Should we look at more of an 8-hour shift? And again, our whole goal is to achieve the quadruple aim of a better patient experience, improved population health, well-being for our care teams, and reducing costs. So as we think about North Carolina's hospitals and health systems in the big picture, we are keeping North Carolina healthy and economically strong. We've seen how, in some cases, most of the rural parts of the state per capita benefit from the economic impact of hospitals and health systems, more so even than the urban areas. But we are facing a workforce shortage. We are trying to figure out the best way to address these gaps, but we certainly need our help from community partners and others. And we want to be committed and continuing to work more, not only at our local level, but the statewide level as well, to work with businesses and economic developers in their communities to meet the healthcare needs of the region, to address population health, and to provide care for everyone in our communities, regardless of their ability to pay. And we know that the more community members that have insurance coverage, the better off it is for all members of that community. So I'm happy to answer any questions. Thank you.
What kind of relationships have you forged with the community college system in North Carolina to address some of the workforce shortfalls that are coming?
So the community college system recently started, or at least we're recently engaged, they may have started a little bit before, these statewide forums that meet twice a year, where they work with industry leaders from all different industries to make sure that we're talking about our workforce needs and they are clear on what those are. And then in specific areas with specific schools, I think the hospitals tend to work directly with the community colleges there as well. So I think a lot of that local communication and coordination is taking place. So now we're trying to make sure it's done on a statewide level. So if there are statewide programs, that we are aware of what they are and we are participating to represent the healthcare part of the economy.
How about within the high schools? Because that's where you need to get to the students while they're making career decisions.
I don't think we have made as much progress yet with the high schools, but that's certainly something that we are working on. Our policy development committee that I think someone spoke about earlier has started a workforce group that we are trying to address not only the pipeline issues, which I would consider a workforce supply, and how do we work better with our K through 12 schools. I know that some of our hospitals and health systems do outreach in their local communities, but again, on the statewide level, I think that's the piece that we've been missing, that we're trying to figure out the best way to address it, and we plan to do that through this group that's meeting. One of our challenges, I think, on a statewide level is we're not sure. We know what the vacancies are from our individual hospitals, but I don't think we have a good snapshot in time of what is going on by occupation. So we know that we're short of physicians in some areas, but when you speak to certain hospitals, so in the Elkin area, they haven't hired a new primary care physician in that community in 10 years. And I don't think they're alone in that, but we don't have good hard data on what those shortages are by occupation. So we know that some parts of the state are hiring nurses from the Philippines because they cannot recruit nurses from the US to come and work here. We know that some areas can't keep occupational and physical therapists, but that's not true for every area. And then I talked to one rural hospital last week that said they don't have any shortages of they don't have problems recruiting specialists. maybe a little bit on the primary care side, but they don't have physician shortages. And I would think that makes them unique. So one of the things we're doing, we've worked with SHEPS, and we're working with a couple of others to try to get real-time data by occupation of what those shortages are in each part of the state, so that we can better direct our efforts to either go to the community colleges or go to the K-12 schools and start talking about what we think the occupations of the future are. One of our hospitals in the Sandhills told us that they looked at what their all-in package of wages were for a starting nurse, an RN, and if you count wages and everything else, it was around $80,000 a year. And I mean, I don't know that most students know that. I don't know that they're aware that these are great jobs with good wages that you can get working right out of school. Sure.
Stephanie, given the Affordable Care Act and the shift from inpatient to outpatient, the emphasis on everything really shifting to outpatient, is the NCHA capable of, or do they have the ability to determine the economic impact of that shift? So, for example, we have a sole community provider here in this community, but we have several other, not necessarily hospital-affiliated outpatient situations that are very close, and they certainly have an impact on the hospital's ability to continue to deliver care on the outpatient side. Is NCHA able to capture the economic impact of multiple outpatient either facilities or providers of outpatient health care and its impact to the hospital and community itself?
We have not attempted to do that. It would have to be a separate study, because what we took for this study was just what we had from our hospitals. And it made it a more precise study. Usually you don't get the kind of specific data that we got from our hospitals. So we would have to figure out if the non-affiliated providers were willing to provide us with that information. And then I think what we're talking about is not only economic impact, but maybe fiscal impact as well. So we could figure that out. Certainly we try to do that for various pieces of legislation, and we have attempted that for various versions of the Affordable Care Act. Some of it is easy to do and some of it is not easy to do, and you have to make a lot of educated guesses.
Just when you thought you could get out.
Oh, great. I'm happy to answer this. So this question reads, notwithstanding the uncertainty of efforts to repeal the Affordable Care Act, what economic impacts would expanding Medicaid have locally and/or statewide? So I can't speak to the actual economic impact, the numbers, without running it through M-Plan, but the state has done that before, and the economic impacts were very large and in a positive direction. So I think the way it worked was by providing more people with coverage under Medicaid. I can't remember the estimates of the number of people. I want to say it was 200,000 or 300,000 additional people that those folks would be more likely to seek medical care, and they would be more likely, there would be more demand for those services, and that would increase the number of jobs and the output from an economic impact standpoint. I would say that if you want a specific number, I think the state of North Carolina has done that analysis, and you can probably find it in the Office of State Budget and Management's website if you Googled it. But it's been a couple of years. The next question was, the cost of insurance is an issue. Can anything be done to control their fees? They make large profits and spend millions of dollars for non-medical areas such as college football programs and stadiums. So I think they're referring to insurers in the way this is written. And that is a legislative issue, and certainly one that I am not qualified to address. I would say that certainly healthcare expenditures and the cost of healthcare is part of the quadruple aim and what we would like to see lower. So the goal of the quadruple aim is to lower cost, to improve quality of care, to improve the patient experience, and to make sure that the care team, the people who are the workforce that's serving these patients, are well cared for. And that is done in part through, that is what I think the Affordable Care Act was attempting to do, but I'm not sure that everyone saw the same reduction in their costs. So thank you, and I'm happy to answer others as we get them. Okay, thank you very much.
On behalf of the Chamber's Governmental Affairs Committee, Stephanie, thank you for being here today and your very informative program. And I appreciate you addressing the workforce issue because that is something that is very dear to the Chamber. And so I hope we can get that message out that there are job opportunities for our young citizens in the healthcare industry. I also, again, want to thank our sponsor, First Citizens Bank, our media sponsor, the Daily News, and our partner, the City of Jacksonville, for the use of these facilities and their assistance. If you missed any part of this forum, just check the listings on G10 for the rebroadcast times and date. And with that, ladies and gentlemen, we stand adjourned.